You can begin, Elaine.
Okay. All right. Good afternoon, and thank you for joining us today for our healthcare update. This program is being recorded and will be available to all attendees and other members on our website. Before we get started, I just want to share that attendants are currently muted for today's program to avoid background noises. However, if you wish to ask a question, we encourage you to do so by typing in the Q&A box, which is located either on your right or bottom of your screen. Time permitting, we will do all of our best to answer all your questions at the end of the presentation. If we run short of time, we may need to follow up with you afterwards. We are over a year into the pandemic, and not only has it captured our lives and our businesses, but it has really captured our healthcare providers and them that are taking care of all of us on the front line. This week, South Carolina has released that they now will start giving the vaccine to everyone over 16. And even though we have more vaccinated, we still hear of new strains and numbers increasing in other states. I want to personally thank Dr. Biggs, Chief Medical Officer at Trident Medical Center, and Dr. Aliberio, Vice President and Chief Medical Officer from Roper St. Francis, for being with us this afternoon to give us this update to let us know where we are with the pandemic, the vaccine here in the Low Country, and to see what our healthcare systems are looking at. And at this time, I'd like to thank both of our speakers before we start, but I would like to turn it over now to Dr. Biggs. Thank you, Dr. Biggs.
Thank you, Elaine. I thank the Chamber for allowing us to share, as you described, a year's worth of work and where we think we're headed as we move into the next phase of vaccinations. When I've done similar presentations with community groups, I like to start with this slide to bring into context where we are today. And what this really reflects is these blue bars are patients that we have admitted or they're in our health system hospitals on those particular days. And they pretty much, in terms of those peaks, align with the state of South Carolina. And it's fascinating because it's the intersection of public policies, disease burden, and then obviously social dynamics with holidays, et cetera. And so if you look at when we started this time last year, and we shut things down in the March, April timeframe, that first entity was on the 5th of May with South Carolina reopening. And then you have Memorial Day, and then if you accelerate it, that's when you had the 3 counties issue a mask mandate around the 23rd of June. Well, if you look at where that curve went for the state, the House was already on fire when we looked at social policies, public policies to battle the pandemic. And we, of course, rode the surge down. Our peak day was the 23rd of July, similar to all the other regional health systems you'll hear about. Went down, Labor Day happened, and then we kind of went into a low trough in the October, September timeframe, which was nice. Then, of course, we had COVID fatigue, frustration, so on. Thanksgiving, Christmas came, and we built that next surge that was really through January and into February. And then we saw that curve start to go down in late February. But if we look at what's happening today, and you're hearing about it, certain clusterings, the governor has just announced, at least in the Low Country area, we're seeing opening of restaurants, bars, population standards, but we're starting to see at the very end of this graph, the cases and the admissions are starting to bundle back up again. And I think it's important what Elaine mentioned is that the state of South Carolina is vaccinated under 20% of its populace. So I think it's key that access is being expanded. But I think in the context of where we sit, less than 20% vaccinated. And I'll share with you in a minute our health system's experience with what the vaccination rate was. We're the intersection of disease distribution, hospitalizations, and what we look at in terms of public policies, where we're intersecting and where we may be a bit divided. So kind of in a snapshot where we've been as a health system, and Trident Health encompasses main Trident Medical Center, Somerville Medical Center, and our freestanding emergency departments and other venues of care. So over 20,000 individuals tested, almost 1,500 admissions. Peak day, as we described, upwards of almost 90 in July. Average length of stay is about a week. If you're in the ICU, it's a little bit longer. We've seen 192 COVID-related mortalities, with the peak being in July, with an overall mortality rate of about 11.8% if you get hospitalized. If you end up on a ventilator, which is contrary to some of the news stories you hear about of these salvage patients being on a vent for 3 or 4 weeks and walking out of the ICU, I'm kind of here to tell you that's not always the case. A lot of times ventilatory support with a COVID patient can be the beginning of the end, and the data will support that. When we rolled out the vaccines in December, currently we're at about 70% health system uptake. So all of our healthcare workers that have rolled up their sleeves, we're at the 70% rate. And we did another almost 6,500 to phase one other healthcare workers within the 5-county region. We've not been unimpacted. We've had 11.5% of our workforce affected by COVID. We've had various pay and incentive support programs to support the workforce. And as we've seen some healthcare contraction, we've lost 33 nurses to either career changes that COVID has brought about, or they chose to take very lucrative travel assignments elsewhere, where they could go and work somewhere for 3 months and potentially pay off a house or a car. So we've seen that. And then we survey continually our healthcare workforce of how are we doing? Are we on target? Are we meeting their needs? And we've seen some high favorability with the training readiness and the way we've communicated. Public policies, we still screen and temperature assess all visitors and staff in the 2 entrances that are open at our main campus. We're allowing 1 visitor per patient, none for COVID positive individuals, and we're still screening all surgical patients before surgery. And importantly, when we went into this pandemic about a year ago, the regional healthcare systems, that's Trident, that's Roper, that's MUSC, the VA, and the East Cooper system were on calls twice a week, putting our policies in synchrony in terms of visitation, access, testing, what we were doing, what we weren't doing. And those continued well into the fall and continue as needed today. I'd highlight a unique thing that we brought on board at Trident was the use of the monoclonal antibodies, which are synthetic antibodies are made in a lab from harvested antibodies from COVID survivors. We've had a very aggressive program and infused over 750 people with either bamlanivimab or Regeneron, which we were the first within our parent company, the Hospital Corporation of America, to do it, or begin doing it in November. And to date, we've had more people come through our antibody clinic than any other clinic in the Low Country and for our parent company. The results speak for themselves. We've had a 97% cure or hospitalization mitigation rate. And so when you model those numbers, we believe we've avoided anywhere from 80 to 90 potential hospitalizations related to COVID by getting these antibodies into individuals before that 10th day of their symptoms. We partnered regionally with Palmetto Primary Care and the Federal Clinic to get those patients into us once they were identified. And we uniquely, there was a local nursing home actually in Berkeley County that reached out to us in February when 24 of their residents were COVID positive. And so we shuttled those patients 4 at a time to the antibody clinic, infused every single one of them. None of them went on to require hospitalization or obviously passed from COVID, which when we think about the nursing home narrative 12 months ago was a very, very different story of what a COVID outbreak would look like. So I'll come back to antibodies later as an enduring strategy, but I'll tell you, this is who we've been. These are your coworkers, your neighbors in the area, because our numbers look very similar in the Low Country to everybody else. This has been predominantly a disease process that's disproportionately been impacting people of color, African American and Hispanic Latino, and just slightly more females than males with our health system data. But as we continue to hear, COVID is spreading, moving, transmitting itself as a disease process of 20 and 40-year-olds. Those are the individuals that we're seeing with positive testing. Perhaps more mobile, continuing to work, continuing to move in social circles, but the lethality of what we have seen, most of the mortalities are distributed across those between ages of 70 and 90, as you have heard reported across the state. Now, to give you a regional health system snapshot, the high water marks are compelling. We were at almost 90, but and you'll perhaps hear later about the Roper St. Francis. Their high water mark was 146. MUSC was 110. VA and East Cooper were much smaller numbers, but we're all sort of living in the mid 20s, low 20s, currently week to week is what we look like. And this is kind of steady state in comparison to what our high water marks were with COVID inpatients. So enduring strategies that we know will work. Vaccine distribution is going to be incredibly key. We were, I think, very, very fortunate to see 70% of our healthcare workers agree to roll up their sleeves and take the vaccine. I think our country placed a lot of trust in healthcare workers, designating them to be the first recipients of the vaccine. And so healthcare systems, and there are healthcare systems that did probably far better than we did, and some that probably did not. But I think it's going to be a regional issue of what your vaccine distribution looks like. But I'll highlight, and I think it was one of the things key to Berkeley County, is that if this vaccine is not taken to certain high-risk populations that right now a lot of times are occupying our beds in our health system, we're going to continue to see COVID continue for many, many more months. Even with the vaccine, even with antibodies, there's still going to be a huge focus on masking, social distancing, social gatherings, symptom awareness. Those are going to be enduring strategies going forward. And I have to advocate that we need to be making our public policies of what we're going to open, how we're going to open it, what it looks like based on data. And by that, I mean, what is your COVID testing rate in your community? How many people with COVID-19 are filling up your ICU beds or your general medicine beds? And what's been your regional uptake of the vaccine? And I think there's a lot of, we can answer the question about disease prevalence and hospitalization rates, but until we get to tomorrow, when the vaccine is being made available to all South Carolinians, we're not going to know what our vaccine uptake rate looks like. But those are three key things to guide what reopening looks like. And as I highlighted, the increased use of monoclonal antibodies in the outpatient non-hospitalized setting is a real game changer. We've seen it. And I think we need to see more of it as an enduring strategy, because those individuals that don't choose to get the vaccine, they will have to grow their herd immunity by most likely being exposed to COVID. And one of the ways to transition them successfully, as opposed to being admitted to the hospital, is through the antibodies. I like to include this graphic, and I hope many of you have seen this on billboards on the highways. This is an example of collaboration between your region's healthcare systems of continuing to message the value of masking, that despite the vaccine being available, despite hearing fewer stories of perhaps individuals being hospitalized, COVID is still out there, still requires masking in the same discipline that we were applying 6 or 12 months ago. We're probably going to be living with this mindset for at least another 6 months until we see what the true vaccine uptake rate looks like regionally. Thank you.
All right, and I'm trying to share my screen. Let's see, here we go. And hopefully this is getting there. How are things looking for folks?
It hasn't come up quite just yet, but we can see it.
See if I can new share. We're all living through, Zoom technology. It used to mean moving real fast. And now it means sitting in front of a screen. So the definition of Zoom has changed considerably since March of 2020. Is that
So-
working now?
Yes, it is.
Okay, good. All right. Well, my name is Bob Oliverio, and I'm the Chief Medical Officer for Ambulatory Care and Population Health. I think Dr. Biggs gave an excellent overview of the epidemiology and the effects of COVID-19 on the population and the hospital functioning. And to his points earlier, yes, we were in the same sort of situation, understanding that we probably started later into the first surge than most of the country. We were hearing more about it. We had some time at Roper St. Francis to develop a testing strategy to help the population, particularly businesses who were concerned about patients and teammates who were showing up with either possible symptoms of COVID or known exposures to COVID. And so that, our initial strategy was to, identify and isolate. And that's what we did up at the North Charleston Rear Transitions Clinic testing site. We had a drive-through testing site where we took basically all comers who needed testing and tested there, testing up to 250 patients per day, and closely monitoring rates of positivity. And as Dr. Biggs mentioned, we saw that horrible increase over the summer, where Charleston now was in the news back in late June and early July, not necessarily as a place to live or a great place to visit, but as the #1 leader of COVID positivity in the United States. That was probably the low point for us, along with Dr. Biggs's organization. Roper St. Francis has 4 hospitals, newest in Berkeley County, opened October over a year ago. And we had to quickly cohort and isolate patients and develop a strategy to admit patients as needed to be admitted, but keep our teammates and other patients safe. And I think Dr. Biggs mentioned the fact that that was one of the early things that we did in terms of trying to figure out how to manage this. And the beginning portion of this, the governor actually mandated a cessation of elective procedures. So those are procedures that people come in and want to get, either knee replacements or colonoscopies, things that are not emergent or urgent. And so we actually were hamstrung in providing the required care for a community our size in order to pivot and take care of a pandemic. And I think we all experienced that within the Low Country. I know our friends at Trident, MUSC, East Cooper all went through this. Dr. Biggs's organization has done remarkable work with regards to bamlanivimab infusion, and they're basically a shining star when DHEC talks about how this is rolled out. We're doing it not to the amount that Dr. Biggs's organization is doing. We've done about 250 cases thus far. There's a new combination medication that will be available, starting April 1st. Basically, we're giving this medication at 3 sites. The St. Francis site, our site in Moncks Corner in Berkeley County, and then we also give it at Roper downtown. So we try to make that available across the community. I will say right now, with the case rates being what they are, demand for that has decreased somewhat, but it's still available, and it's still going to be necessary. To Dr. Biggs' point, the pandemic is not going away. until we get a herd immunity of at least 70% and probably closer to 70 to 80%, we're going to see significant illness in the population, and we're going to need to be able to provide the medication across the region. With the emergency use authorization of the Pfizer vaccine initially, and then quickly thereafter the Moderna vaccine, we thought it was really important if we were ever to think about getting to a new normal, we were going to have to put a lot of effort into vaccinations. And so starting December of 2020, we really sort of leaned into that effort. And we began hospital-based vaccinations on December the 15th. And we had a similar experience to Dr. Biggs's organization. About 70% of our population thought it was a good idea to get the vaccine. We did a considerable survey of all the folks who were designated in 1A, that's the healthcare workers who needed to be vaccinated initially. And a lot of the reluctance for vaccination reflected what was going on in the community. Folks were concerned about the rapidity of vaccine to market. The fact that this was called Operation Warp Speed may make people think that things were skipped or sidestepped. And we took a very deliberate approach to education with regards to what does the vaccine do? How is it determined to be effective? How is it determined to be safe? And the reasons why you should get this vaccine. So again, we have about 70% of all of our teammates vaccinated, and spending a lot of time addressing issues of vaccine hesitancy. Once we finished our teammate efforts, we really wanted to have a sustained source of vaccine for the Low Country. Again, this really depended on the availability of vaccine. And, I think as Dr. Biggs probably well knows, that was very tenuous for the first 3 months of this effort. We were given the Pfizer vaccine. And that was because, health systems are better equipped to handle the Pfizer vaccine. That's the one that needs to be kept at ultra cold temperatures and requires 2 doses. So if there's a vaccination strategy that's as complicated as you can kind of get it, that's pretty much it. You can't handle it. It spoils quickly, and you've got to give 2 doses. So you have to have people come back in 3 weeks. And so those were all operational issues that we had to overcome. And we really wanted to, provide a quick experience for, the patient, so that, of all the things that we don't want to do, we don't want to make getting a vaccine a burden or cumbersome. So we developed a mechanism to take appointments. And one of the deliberate strategies was to schedule appointments so that, we were able to level load, vaccine throughput. So when the vaccine came out, I'm sure everybody saw on TV, pictures of, in Florida of cars just backed up on the highway. And that was one of the issues that we wanted to avoid. So taking appointments was very important in level loading our vaccine demand so that, throughput was smooth. Additionally, we made the second appointment when we made the first appointment, and would not take a first appointment if you weren't committed to having a second appointment. So we wanted to get the 2-shot vaccine regimen in. Governor McMaster attended our grand opening on January the 19th, basically said, go full bore. And then we had some considerable difficulty throughout just trying to get vaccine for our residents, and then looking at our underserved folks. So thus far, we've vaccinated approximately, provided about 40,000 shots since we began our efforts. As Dr. Biggs mentioned, despite that effort, I mean, we are still at 16% of South Carolinians having two doses of the vaccine or being adequately vaccinated. 1 in 3 of us has gotten at least 1 dose. So, our efforts were not only to, supply an area where people can come to get the vaccine, but we were approached by DHEC to partner with regards to underserved areas. Berkeley County in particular was shown to be underserved. Now, this can be confusing in that vaccine allocation is often done through institutions that accept vaccine and then distribute it. So MUSC got a lot of vaccine, and we got a lot of vaccine in our institution. Charleston County, when you look at the numbers, it looks like they got about 139,000 shots as of about 3 weeks ago. Berkeley County got about 4,000 shots. Dorchester County got a little over 6,000 at that time. So DHEC actually was very interested in providing a mass vaccination type experience for patients within Berkeley County. So we had 2 main objectives doing that. Number 1 was get vaccine to residents. Now we couldn't keep other people out, but we wanted to make sure that we had outreach to residents that needed the vaccine and were unable to get to our mass vaccination site at the Coliseum due to whatever barriers there were. So that was issue number 1. Issue number 2 was really address the racial disparities in vaccine administration. So our own numbers, we saw a little over 16% of our population were people of color, and that is considerably underrepresents what the population of the Low Country is. It's about half of what the population of the Low Country is. So we knew we had to make some inroads into folks who, for whatever reason, were not able to get the vaccine, decided not to get the vaccine. And we engaged our Director of Community Health, Kimberly Butler Willis, that's her on the right, and did some outreach. And over the course of a week, we're able to deliver a little over 4,000 first doses to residents in Berkeley County. And our percent patients of color increased from 16% to a little over 50%. So we're very happy with that outreach, and that's going to remain a part of our playbook when it comes to local outreach. We're also partnering with local charitable organizations. This is Palmetto Palace. They have a mobile health unit that is available for transporting, healthcare and now vaccine to very rural areas. So we've done that over the past 2 weekends and have vaccinated a little over 900 people thus far. So all told, with the effort in the hospital for our 1A, expanding to 1B, and now accepting appointments for 2, which is basically, like Dr. Biggs said, everybody over the age of 16. We're going to be continuing our presence in North Charleston. We think that's a great location in that it's accessible to all the areas of the Low Country. It's a quick drive-through, and we have the capability of doing between 1,600 and 2,000 doses per day. And it really is all about vaccine supply. And so, our limit is the available vaccine to give. So that's our strategy for, you know, our area of the Low Country. We've sort of moved from isolation, identification, mitigation to vaccination. And again, it is going to take time. This is not going to end the pandemic anytime soon. And as Dr. Biggs said, we are going to have to be very, very careful about how we approach reopening and watch our positivity rate to really inform us as to what kind of social measures can be loosened and what kind of how we open our businesses. We need them open, but we need to do it smartly. Otherwise, we're going to end up in the same place we did back in June of 2020. So that's my prepared remarks, and I think Dr. Biggs and I are available for questions.
Thank you. We do have a few questions. Dr. Oliveira, when you mentioned about, you know, opening up the businesses safely, what would you recommend? What recommendations would you give to businesses who are opening their doors?
Well, one of the issues that we've had is the lack of an organized and consistent public health policy when it comes to masking and social distancing. I think that's been one of the issues that we've had. I remember being in the Mount Pleasant Town Council meeting and just narrowly passing a masking requirement for the town of Mount Pleasant. And we have to do that municipality by municipality. You know, at that time, the federal government pushed guidance down to the states. States pushed guidance down to municipalities, and a lot of times, you know, businesses became sort of the arbiters of, you know, public health, which is not the way it should be. But you know, I still think we are in a position and in a condition where we have to mandate masks inside. You know, outdoor dining is one thing. The second, you know, the thing that I see that gets me nervous is enclosed tents and folks going into closed spaces, essentially outside of the four walls of the building. You know, we have to do these things, you know, smartly. Otherwise, we're not going to be able to maintain an open status for our businesses. So I think that's probably the most important thing is, you know, folks need to wear their masks. They need to remain socially distanced. They need to wash their hands. They need to avoid large gatherings. Those are the keys that will get us through until we get to a herd immunity. Dr. Biggs, anything else you'd like to add?
Yeah, I think we all have our own degrees of COVID fatigue, of you know, where we would like to see this end up. You know, but unfortunately, you know, when you start seeing increasing rates of positivity, and you're putting more people into your COVID units, you've lost really the momentum, the message of what we could have or should have done. And I think we have to ask our community leaders to go back to the numbers. Early on, the regional health systems were having calls with regional leadership of when should we open, what should it look like, because there's a lot of mixed messaging out there. But if we just rely on what are the numbers telling us, how effective was the vaccine uptake rate, but more importantly, what are you seeing with testing rates, those should really be guiding the decisions. Because a failure to launch on a reopening, which I'd have to say, if we hate to retrospectoscope everything, but if we look at kind of reopening South Carolina in May of 2020, that was probably a mistake. And the numbers bear that out. That's when we saw our huge surge, because notionally it was reopened without a lot of the dynamics that you've just discussed with distancing, masking, what is safe, what is not safe. You know, and in healthcare, we can't pretend there's not economic drivers. And I mean, just look at the school system toll of what it's been like shutting schools down with limited in-person instruction. I think it's been perhaps incredibly catastrophic on a lot of family dynamics and the impact of children, this generation, who knows what that's going to look like going forward. But it's got to be a balance where what you reopening at the same time, you're balancing that on what is your disease posture and what you're seeing in your communities.
Thank you. Can you explain a little bit more on herd immunity?
I'll take that. That's a softballer. Herd immunity is when the notional community becomes protected from the pathogen. In this case, it's COVID-19. You're only going to get to that in one of two ways. Either number one, you get COVID during this process, and in theory, your body has made protective antibodies that were you to be re-exposed, your illness should be less than what it was initially. That's pathway number one to herd immunity. Pathway number two is what we're really focusing on today, which is vaccines that give you a synthetically modified booster of what it would have been like had you actually been impacted by COVID-19, but your body makes those antibodies in response to what that vaccine triggers your immune system to do. And so either pathway, infection, which for those who got COVID-19, sorry, we're still saying you need to get the vaccine too. Obviously, when you're asymptomatic, not actively in the disease process and the timing aspects, and whether it should be 2 weeks, 90 days, 30 days, it changes. But the bottom line is you should get the COVID-19 vaccine, even if you've had COVID. And for those who didn't get COVID-19, the vaccine is that pathway to grow herd immunity, which means COVID-19 is going to live in our human system probably for years and years and years, like many other coronaviruses, but its lethality and ability to impact people negatively through either previous infection and or vaccination, it will be less and less of a negative threat, unlike what we've seen in 1920 and into 21 with the newness of this new pathogen.
Yeah, I would just add, if you think about measles, and measles is incredibly infectious, but you hear about an outbreak and it makes news, and there's a reason for that, and that's because about 95% or more of the population is immune to measles, and so you just don't see it unless you have pockets of areas that are not immune, that they're not immunized. So that's what herd immunity does for you. It can turn COVID into measles over time, which is the hope.
And I'd even add, when people who are on the fence about the pace of which this vaccine was created, well, I think in medicine, we look to history to guide what has worked. And let's think about measles example was given. Let's talk about polio. In 1955, Jonas Salk discovered, a protective way to eliminate polio. It wasn't until 1979, from 1955 to 1979, where you were getting polio throughout childhood, both as an oral and as an injection vaccine, for us to really eradicate polio. Now, there's still some developing third worlds where you'll see polio cases. And so if you think about polio, a worldwide threat, just like COVID, from 1955 to 1979 to get control. And we've come up with a vaccine in essentially 10 months, brought it to market and distribution in 12 months. That doesn't mean corners were cut. What that means is you had healthcare, biotechnology, thinking about this problem much like the way we did in World War II with the Manhattan Project, which meant you diverted resources, people, energy to focus on one thing and one thing only. And when you do that, you drive an incredible pace of change and improvement. Still the rigors, the human subject protections, and the way we go about looking at the effectiveness of vaccines, all of those rigorous standards were in place and are still in place. So I think we should step back and say, rather than with healthy skepticism, which is always a fair call, we should be thinking, my, what an amazing worldwide effort of mostly driven from US-based biotechnology forms, but a lot of European ones as well, sharing data. That's why you have multiple companies producing the product, but it's really the same template. So I would say balance the skepticism with sheer amazement of what, healthcare, business, governmental leadership can do when they focus on one problem.
I have a few more questions as it relates to the vaccine. So how long does the vaccine protect you? Is this a vaccine that we'll have to get every year, like the flu shot, or is it one and done?
Well, I think it's always been said, Yogi Berra said, predictions are really hard, especially about the future. It's hard to say, but, based on what we're seeing with new variants, and that's something that, we can talk about, the longer we remain unvaccinated, the more time this virus has to mutate, and can make it less susceptible to the antibodies that are produced by the vaccine. So over time, if we don't get a hold of herd immunity, we may see variants that just are not covered by the vaccine that we're giving currently. Now, the good news is for the variants that we're seeing in this country, by and large, the UK and the South African, it looks like the vaccines available still are effective against these variants, but there are other variants that are of concern or of interest that we're watching closely. If these things get out of control, we may find ourselves in a situation like the flu shot, where we have to sort of modify the vaccine based on the virus that's around at the time, and that can change. So I have a feeling, and this is just me, but I have a feeling we may be in for something like that. And I welcome Dr. Biggs's view on that.
Yeah, I think, looking back at history, when H1N1 was creating a lot of problems in 2008, 2009, what we saw going forward is that the seasonal flu makers that would blend what we think the biggest pathogen will be that flu season, we're taking elements of H1N1 and putting into the seasonal flu. I think we're going to see something similar to that with COVID-19 and whatever combination of variants we think that are most pathogenic. Probably not until 22, 23, once we vaccinate the whole world, then I think it'll be easier to put those safety measures into our seasonal flu vaccine.
How effective is the one-shot vaccine compared to the 2 shots?
I guess it depends on who you ask. I mean, the data is not, you hear numbers anywhere from 70% to 85% with the one dose vaccine, and we, like Roper, we've been using Pfizer because we have the capability to manage it at those temperatures. And I like those numbers because dose 1 gives me 60% protection. By the time you get dose 2, that takes me into the high 90s. I like that, even though operationally that's a very difficult vaccine series to get into people. I think you're going to see single doses in areas that are difficult to get vaccine uptake rate to begin with, but much less will individuals come back for the second shot. So in our country, I don't know that the one-shot series is going to gain that much favor, but we'll just have to wait and see. We've not had much exposure to it thus far.
What I would say is that all of these vaccines do a couple of things very, very well, which is keep people out of the hospital and keep people out of the morgue. So when it comes to percentages, for each of these vaccines, at least as far as we know now, that's 100%. And so, again, what we're talking about is, the incidence or the rate of, mild to moderate to severe COVID, but not needing a hospital or not needing, an intensive care unit, and certainly not ending up dying. So those are important numbers to remember. The one thing I will say is, brand awareness for vaccines is kind of a new concept. I was never knew what brand flu shot I got, or honestly, as a consumer, didn't think about efficacy. I just got it. because it would probably keep me out of the hospital. It's going to be, I think it's going to be the same way for this. There are going to be different levels of efficacy from mild to moderate COVID, but this sniffles and stuff like that, I'm okay with. I just don't want to see people in the hospital, and I certainly don't want to see them in the morgue.
I have children that are preteen. Will there come a time they will need to be vaccinated?
Yeah, probably before the school starts in the fall. I mean, 16 and up right now for Pfizer and Moderna, but we're hearing right now vaccine trials as young as age 9 is the youngest age I've heard at multiple centers across the country. So before the new school year starts, you're probably going to see a dropped age threshold for the Pfizer and Moderna products, which is what our country has seen the most of initially. But yeah, I mean, it would be problematic not to include the pediatric populace in this strategy, because as we well know, they are very, very capable of spreading viruses in the classroom.
My business would like to host a vaccination event at our facility. Is that option available?
It's again, it's one of those things that it's operationally it's pretty complex. We can talk offline, but normally what we try to do is every one of these mass vaccination events, we staff our North Charleston site with about 40 to 50 people, depending on volumes coming through. We have been able to partner with National Guard. At the Monk's Corner, we partnered with Berkeley EMS. And so, we do a lot of work with the local resources to help with that. More likely is probably partnering with a community resource, and particularly if this business is in an underserved area, organizations like Palmetto Palace, Federal areas to vaccinate, particularly if we're hitting underserved folks or folks that are hard to reach. So, I mean, there are a lot of provisos in that answer, and it's not a firm answer, but I can provide my email information and hook whoever asked this question up with resources in the community to explore the options.
And Dr. Biggs, did you want to add anything?
No, we have not, been in the setting of doing large community vaccination events, mainly with challenges of vaccine distribution that we've watched, our colleagues, MUSC and Roper, go through the great pains of coordinating something that's incredibly complicated. The easiest part is putting the needle in the arm. The work behind that is colossal. And when you get your weekly allotment, and we don't want to bore you with the nuances of just how DHEC is managing this to the minute, that when you don't get what you're expecting and you've got to take appointment times down, what a letdown that would be if you're a potential vaccine recipient. I'm getting a feeling, though, that the governor didn't arbitrarily pick the 31st of March for no reason. We're seeing in our organization offers of vaccine quantities. I ask for a certain amount every single week. And let's just say last week was a bit like Christmas, that what we are in store for coming up is going to allow us to do some unique things, because let's face it, if we look at the need is out there, but we really haven't built the supply to distribution. We've created notional concepts of, oh, you'll go to retail pharmacy. Well, when's the last time you saw a retail pharmacy on the corner that could accommodate more than 15 cars in its parking lot? So those are not going to work. And we heard early on that Walmart was going to be a huge player in this space, which was a brilliant idea. They're everywhere. But I got to tell you, has anybody heard of any Walmart anywhere in this country giving the vaccine? And no, they've not, because they've not been given assurances that the vaccine supply and distribution will get to them so they could set the operation up. With the numbers we're hearing right now, I would say over the next 2 to 3 weeks, you're going to see vaccine distribution change in amazing ways to where people are going to have access to it, unlike what we have seen in the past couple of months. And so I think that's very promising, and avenues where you would bring the vaccine to a workforce. If it's a large workforce, I think those are on the table as well. And you look at your big entities, once you take healthcare out of it, you take MUSC, Trident, Roper out, who are you left with? You're left with Boeing. You're left with some of the major parts manufacturers that are supporting either Volvo or Mercedes-Benz. Those would be ideal areas to partner in a vaccine exercise to get that workforce vaccinated, so they don't have to leave and find retail pharmacy or a Costco or whatever it looks like in their neighborhood.
What is the current position on getting vaccine for those who've had COVID-19? Is there a preferred time frame between having the virus and receiving the vaccine?
Yeah, if you go to the CDC website, and early on, what they said was, as long as you're asymptomatic for at least 10 days, you can go ahead and start your vaccine series. But then they've also posted another set of guidelines that speaks notionally to the time frame of 90 days. Why that change? Well, maybe because at the time that was announced, vaccines were coming out, we didn't have enough. And so the idea of thinking if you had COVID, you're probably going to get some innate auto benefit from having had COVID. So let's let you wait 90 days versus 10. I think you're going to probably in the next 3 to 4 weeks see CDC walk that back to what they initially were saying, being asymptomatic, afebrile, otherwise recovered, and 10 to 14 days out from your last set of symptoms. But the key thing being you need to get the vaccine even though if you had COVID.
Yeah, that's we have not turned away people who have been within the 90-day time period, just because number one, it's really hard to do that when you're doing a drive-through vaccine, and number two, they are, like Dr. Biggs said, they are going to need the vaccine. They're there. We'll give it to them. So that's the thinking behind the 90 days is use your immunity you got from your infection and let somebody else have the vaccine. To what we had spoken to earlier, I do see, there may be improvements or decreased requirements for, handling these vaccines in terms of, cold storage. That's maybe on the horizon. Moderna is something that you can manage at a clinic if you have a reliable supply. So, one of the things I think we'll see the vaccine seeping out into the community, particularly in, local physician offices, where you can get access to it a lot easier than, sitting through a drive-through lane. And I would much rather give vaccine like that than have a mass vaccination site anywhere. And so that's one of the things. Probably won't see a lot of Johnson & Johnson, the one-shotter here. AstraZeneca's coming out, and that's another 2-shot regimen. And the other two, Pfizer and Moderna, are 2-shot regimens. But, of all those vaccines, with the exception of Pfizer, you can handle those at a clinic level, which would be, really beneficial, I think, to the population.
And we'll make this our last question. Is there a time frame when we get a true hold on this pandemic?
I'll leave that to Dr. Biggs.
Yeah, I'm going to head to Vegas right after this answer. It goes back to what we talked about. You've got to look at what's the distribution of COVID, how many people in your community are testing positive, how many people are filling up your hospital beds. And hopefully soon we'll know what the vaccine uptake rate is, because logically, we've both quoted 70% uptake rates. Do I think that that's what we're going to see in the community? Gosh, I hope so. But I think we're looking at, best case scenario, maybe 45 to 50%. And what we really need is 70 and higher. Well, healthcare workers that have been living and breathing COVID and seeing it in front of their faces for a year should be the first ones wanting to get the vaccine. So I think we're going to have an ongoing strategy where we're going to go through April and May pushing heavily on community vaccination rates, but we're going to have to do it again in June and July and when schools start to say, hey, I get it. Because a lot of my colleagues in healthcare said, you know, I'm going to watch these people get the vaccine and see what their experience is. And that was the case, but we've picked up a lot of our healthcare workers when we're doing that third round of day 21 dose number 2. We've picked up gains. I think we have to look at our communities the same way. Don't measure our success on who lines up and rolls their sleeve up for shot 1 tomorrow, for example. Look at that number when we are in June and July of how many now that we've added to get dose 1s, because people are going to look and their coworkers, they're going to ask, well, why did you do it? Or what were you thinking? Or what was your reason? And I think we have to be patient because the experience of healthcare, the vaccine uptake rate is a little bit different than the community at large.
Yeah, I think vaccine hesitancy. I mean, and basically, yeah, vaccines do not, save people. Vaccinations save people. You got to get it in arms, and so if you don't want to get it in your arm, that's not helping anybody. And so addressing those reasons, which are not monolithic. I mean, everybody has their own concern, and it's taking time like this to talk about these issues. Sort of explain, the process, the safety, the efficacy, the side effects. These are all things that people are weighing in their heads before they actually say, here's my arm, you shoot me up. And that's going to take a lot of work. And, and thank you for having this, this forum so we can talk about this, because this is what's going to need to happen over and over again to a number of different populations in the state before we get to 70%.
Y'all have done awesome. It is 2:59. So but I want to tell you how much the Chamber Board and I personally thank each one of you for doing this. This is such a serious situation we're in, and even though things are relaxing a little bit and we're seeing more people, we cannot let our guard down. I went to an event, just to share this with you. I went to an event a few weeks ago and I was the only person in the room who had my mask. And they said, are you worried? I said, I am a caregiver and I'm going to protect the people I care for. And I just feel that we've got to, I'm going to say this, we got to take the politics out of this and let y'all who see this on a daily basis and know how horrible it can be for a family lead us in this. And again, with all my heart, we appreciate it. Thank everyone for joining us today. This will be on our website. We will be pushing it out, and we will look forward to another update soon. And let us know what we can do to help both of y'all. Take care, and we stand adjourned. Bye.
Thank you.
Much.
Goodbye.
Bye.